Hello, my name is Holly Tanner with the Herman and Wallace Pelvic Rehab Institute, and I'm here with Lila Abbate, longtime faculty member. And so, Lila, if you could share a little bit about yourself in terms of your background and some of the content that you teach for the Institute.
Hi, Holly. Thanks so much for having me today. As you have mentioned, I've been with the Institute for, I think, like 10 or 11 years now, and I've been a therapist for 25. I started in pediatrics, and then I started in integument. And from there, I knew I always wanted to do orthopedics. So then I started on my orthopedic track. I have an advanced master's of manual ortho, and then my DPT was also with an orthopedic track. And as I was in one of the courses in my DPT track, they had a pelvic health course. And so my friend says, oh, we have to take this course. And I was like, okay, I don't know if I'm so interested, but I take the course, and then that leads me to pelvic floor 1 because I was only there to find obturator internist. That was what all I wanted. And so then Holly Herman and Kathy Wallace were the instructors for the course. And as you know, they're so riveting and share such good information. And then that kind of took me into my pelvic health journey. I've been full-time faculty at Touro College for 5 years. Currently, I am adjunct at Columbia University, and I teach their pelvic health elective. And so it's been really wonderful to add education to my resume, that I'm able to do some instructing, and I'm a clinic owner, and I own Interventions Physical Therapy, which is located mainly in Long Island, and I have a New York City office as well.
And you have been an instructor in the core series and have just taught so many participants over the years. And you also developed a couple courses. And the one we're going to talk about right now is the Coccyx Course. Can you tell us a little bit about how that course is structured, what folks could expect to learn if they come to that class?
So currently it's put together as a remote course. It was a 2-day in-person that I moved to a 1-day remote with videos. And so the reason that I wrote the course, which was about 13 years ago already, was that there was not a lot of information on specific coccyx treatments. And so when I would go to the literature, it was mainly physicians doing a literature review and or some treatments that were related to conservative methods, but the conservative methods never had physical therapy as part of the algorithm. So they talked about diathermy, heat. They talked about ultrasound, no manual treatment. So then that kind of took me on my journey to put together the 2-day course. I talk a lot about biomechanics of the pelvis. I talk a lot about coccyx and coccyx movement. And, you know, when I put together the idea of treatment, I kind of talk about it in relation from head to toe. You know, what else can be driving a rotation from someplace else? So that's kind of what made me put it together. Talk a little bit about coccyx seating, cushions, injections, how the medical community views coccyx pain, imaging, and treatment on their end, and how we incorporate it from a rehab point of view.
Excellent. And what kind of feedback do you get from participants in terms of what they're seeing in the clinic and maybe some of the struggles that they're having that
Yes.
you really like answering in the class? Yeah.
Okay. So a lot of the participants have taken pelvic floor 2A. And so when they've taken that, they've taken some of the general coccyx mobility, coccyx mobilizations, what to do next. And I feel like the Coccyx course is really geared for that 30% who are really difficult to manage. You can maybe get some of the pain away. You can maybe change it a little bit, but by the time they come back a week later, they are in pain again. So I felt when I put it together, I was looking at what's the why. And typically the why is coming from somewhere else. Because in 2A, you already learn how to do basic muscle energy technique, understanding what could feel like too flexed, what could feel like maybe too extended. And then we go into a little bit more depth about thinking about the biomechanics of the ilia, the sacrum, how that relates to the coccyx, and then potentially looking up at the ribs in the head or down toward the feet. And so even though it's a remote course, I have a lot of pictures. I have a lot of patient cases that I talk about. Everyone gets their questions answered by the time they are leaving and or have an idea of what they can use on Monday.
And you have a lot of videos that you said as well.
Right. So at the end, there are 2 videos. I believe one is 12 minutes, one is 9 minutes that the participants get to keep. And it talks about the basics of mobilizations of the coccyx. I have a little bit of a taping technique that I use that pre-positions the coccyx toward extension. And then I do a little bit of an orthopedic screening. What can I assess? What can I look for at iliosacral springing and mobility? And also like stepping back and looking at the patient from an orthopedic view, from cranium, ribs, thoracic spine, lumbar, and pelvis, and how we can relate that together toward the sitting pain.
That's fantastic. And, don't you find that so many patients come to you having perhaps seen a really excellent spine physician who does procedural interventions? Maybe it's prolotherapy, maybe it's nerve root injections or different blocks. But don't you find still that so many of the medical providers who interact with these patients don't really understand the pelvis? And especially when it gets down to the tailbone, if the patient has been lucky enough to have even some interventions or a look at the SI joint, that's often as far down as providers go. Is that your experience as well? And how have you been able to help shape the interactions in your community with the medical providers in terms of helping them understand that pelvic rehab really can impact these patients positively?
Well, I think that in general, that's almost like every pelvic floor physical therapist plight, like why did it take them so long to get into our office? Can say this with pelvic pain patients in general, like who's minding the pelvis? And there's not one specialty that always looks at it. So for the most part, I have done a bit marketing to the orthopedists in my area who are spine surgeons, just to like let them know that there is a treatment for coccyx and coccyx pain. But it's also painful sitting. Like almost all of our pelvic patients have some type of painful sitting episode that can wax and wane through their symptoms, or can be as of current and what's driving them. So I look at the idea of fanning and folding of the pelvis, just like the hand will fan and fold. I'm looking at, just like you mentioned, a lot of biomechanics of the SI joint. So when we think about the muscle coccygeus, of course, we're thinking about it flexing the coccyx, and if the patient's making a bowel movement, it will lengthen and move toward extension. But then we don't think about it as an SI stabilizer. So then I have to go a step beyond and say, well, yes, I know you have this low back pain as part of your complaint, but remember, 50% of the patients who have coccydynia also have concurrent low back pain. And so then here I am now moving up the chain and looking at their lumbar spine and looking at their sacrum, when most of the medical community is not looking at that as being one of the reasons for it. And blogs are helpful. I have a vlog on my website about coccyx pain and sitting pain. And reaching out to other professionals that you think are, meaning medical professionals that are doing something that's spinal or pelvic related, is just helpful. Even if it's not going to be a patient that they're seeing currently, hopefully they're keeping it in the back of their head that, oh yeah, that woman or that therapist or that rehab person knows how to maybe treat this. Give this person a call. They can maybe at least lead you in the right direction. So that's always helpful.
Excellent. And I'm sure, you mentioned that there are some case studies and examples, and of course, your rich clinical background and all the patients that you've seen with these conditions. That's really, I'm sure, what a lot of participants get a lot out of in terms of the coursework, and get so excited about having you being able to answer questions for them and give examples of what it looks like in the clinic on a day-to-day basis.
Yeah, and I also have cases that I made mistakes on. Like you learn from every single patient that walks through your door. Like I treated a patient who had a long-standing history of a sacral fracture and then had pelvic misalignment when he was thrown from a bicycle getting hit by a car. And so like in retrospect now, when I think about his case, there'd probably be so many different ways I would have treated him. He probably maybe even needed a sacral fusion surgery, like his instability was that severe, but that knowledge wasn't in my mind at the time. There weren't good sacral fusion companies at the time. So it really, hearing treatment errors or mistakes, I mean, that's part of being in medicine. Medicine always progresses. So I feel like it's always great to have good outcomes, but always to learn from some of your outcomes that weren't as fabulous as you would have liked them? And then what did you learn in order to kind of help your next patient? And even like some participants in the class are like, oh, I think I'm going to call that patient from a year ago
Mhm.
or 3 years ago. And exactly, like that's what any class is supposed to do for you. It's you're hoping to walk away with tidbits, and then you're hoping that it sparks your curiosity.
Absolutely. Well, thank you so much for sharing information about this class. I know people will be excited to take it and to learn from you and to again take that perhaps that initial knowledge that they picked up in two-way and got to utilize a bit and now come back to you with all these questions and put all those clinical pearls in their treatment box.
Definitely. Thanks for having me.